فأووا إلى الكهف ينشر لكم ربكم من رحمته ويهيئ لكم من أمركم مرفقا.
इसके बाद मैं हमारे शहर की बहुत ही काबिल एहतराम वली सिफत माहिर अमराज निस्वां गायनोकोलॉजी सीनियर डॉक्टर फहमीदा साहिबा के साहिबजादे मोहतरम हैं डॉक्टर सैयद गौसुद्दीन साहब. बहुत अच्छे कारनामे हैं रोबोटिक सर्जरी से मुताल्लिक़. हमारे सरपरस्त डॉक्टर अब्दुल मतीन साहब ने 4 महीने पहले हमसे मशवरे में फ़रमाया कि इस अज़ीज़ दोस्त को बुलाना है, इनकी खिदमत से फ़ायदा उठाना है. तो इंशाअल्लाह डॉक्टर गौस साहब अपने मुताल्लिक़ा मौजू रोबोटिक सर्जरी. असल तो इंसान है, दिल भी इस इंसान के जिस्म में है, रोबोट में नहीं है. रोबोट का बन जाना किसी माँ का बदल नहीं, किसी बाप का बदल नहीं. रूह की बेचैनी उससे ख़त्म नहीं होगी, लेकिन मददगार ज़रूर है. मशीन से जिस कदर फ़ायदा उठाया जा सकता है उससे फ़ायदा उठाया जाना चाहिए. हमारी बहनों की तरफ से आवाज़ के कम आने की शिकायत आ रही है, कोशिश की जा रही है. दूसरा अल्टरनेट सिस्टम भी अभी थोड़ी देर में लगा दिया जाएगा इंशाअल्लाह.
अस्सलामु अलैकुम. At the outset, I would like to thank the ICRA Foundation, Dr. Mateen sir, who has taken this effort. It's not an easy job to get all these doctors on a common platform, and at the same time, Mufti Sahab, Mufti Jamal Sahab, all of their efforts to gather all the doctors here for today's event. I might not be speaking about the Islahi talks like how our brothers have spoken, but probably a purely academic topic of robotic technology in the medical field. Not to tell about robotics, not to tell about the technology, but to incite a bit of enthusiasm, a bit of encouragement for the coming generations to accept this, to pursue this, and to follow your passions. So basically, I am Dr. Ghouse. I am a consultant urologist and transplant surgeon at Asian Institute of Nephrology and Urology. And we should never forget our ancestry. Is anybody aware that the father of robotics was a Muslim? It was none other than Ismail al-Jazari. He has created more than 100 automations, inventions in 12th century. Such long time ago he had created this fountain, which is even available in Istanbul, Turkey, even now. What you see in airports and 5-star hotels, the automation of washing your hands, you go near it and the tap starts to work. This was invented in 12th century by our ancestors who were the Muslim. But lost is all our destiny. So we need to pursue, we need to excel, and we need to follow our elders. I'll try to finish in the given time, but let me see. So previously the value for surgery was giving a good quality of surgery and with a bit of safety. Though the incision was huge, you take a big incision from the xiphisternum till the pubic symphysis and do a small appendicectomy. If the patient is safe, alive at the end of surgery, it was the value for surgery in the olden days, isn't it? But what is the value of surgery or equation of surgery now? You should have quality, patient should survive, that should be the safety. You should have an entire experience. The patient should feel that he has got the least possible harm during the surgery with the least invasiveness. That is, the denominator is invasiveness and should be done at the least possible cost. So that is the equation of surgery nowadays. Not only just being safe at the end of the surgery and completion of the surgery is no more the equation. The entire experience along with least invasiveness and cost. So to accomplish this, surgery has gone through the eras of open surgery, laparoscopic surgery, and now into robotics. I just want to know how many of you are aware that in robotic surgery it is not the robo or it is the surgeon. How many of you feel that you switch on a button and program it on a laptop to do a surgery and click enter, the surgery is done? Many of our patients come and tell that, why are you so many hours in the OT when the robot is doing the surgery? So it is not the robot, it is the humans who need to do the skill of doing the surgery, but the platform has changed. So basically it was started in 1980s only, hardly around 30-40 years, 3 decades back. Basically it was started, the robotics was started by a defense research, basically to do surgeries in a situation where doctors cannot reach, situation like what we have in Gaza now. It was basically started by an American military and NASA to do remote surgeries. It was approved by the FDA in the year 2000. But again it was sued by one of the other computer companies and stayed indolent for last 8 to 10 years. And only in the last 15-20 years robotics had taken a big leap, and that was because of these two guys, Dr. Mani Menon, who is a urologist, and Dr. Raj Vattikutty. So why I am telling their names is just not to tell that what they have done. We want our own entrepreneurs, our own thinkers, our own people who can get all these things to our community also. And all these leaders are all in this gathering. If not now, in the future, we want all these things to happen in our community also. So basically, Dr. Raj Vattikutty is a philanthropist. Both of them are alive. Recently met them in Jaipur. Dr. Mani Menon has completed more than 15,000 radical prostatectomies in the last 15 years. So these are people who have taken robotics to the nook and corner of the world. Everybody is aware of minimally invasive surgery. Rather than giving big incision, through the small incisions we can get all the possible benefits. So this is the recent growth of how many surgeries have been done robotically. It is exponentially increasing. Also, it is percolating into every field. Maximum utilization is in gynecology, urology and cardiac sciences and gastroenterology. The literature on robotics has also exponentially increased in the recent past. Why is it all this possible? Because one can see the number of cases you take to learn laparoscopy versus the number of cases you take to learn robotics is very less. Within 8 to 10 cases you get the proficiency which you have got after 15 to 25 to 30 cases in laparoscopy. So that proficiency is attained by robotics very easily. Also, the learning curve in laparoscopy is a huge learning curve. You have to spend at least a decade of time learning laparoscopy because you are going to do surgery using chopsticks, long sticks which are 30 to 35 centimeters outside the body to manipulate something inside the patient's abdomen. So that is laparoscopy. But with robotics, even a novice surgeon can get the proficiency in a quick time. So basically, what exactly is robotic surgery? How does it work? You have a patient cart, you have a vision cart, and you have a surgeon console. These three parts are there in any surgical robot. There are many other robots which are available. One of what I am talking is only the surgical robot. There are orthopedic robots, there are rehabilitation robots, there are robots for daily transport and dissemination of so many other goods to the patient. But what we are talking today is about the surgical robo. So it has these three components. What are those? The extreme left is the vision cart, the center one is the patient cart, and that is the surgeon console. Vision cart does the entire processing of what is happening of the vision and the movement of the arms which is there on the patient cart. Patient cart gets fixed to the patient, and surgeon console is the one on which we sit and operate. Obviously the most important person is the one who operates. So robot doesn't do the surgery, the surgeon does the surgery. And this is how the hand movements of the surgeon are translated into the movements inside the patient's abdomen. Why is it important to know about robotics? Because if you are a surgeon and have been operating for past 10-15 years, all this, my orthopedic colleague can get a better picture of all these injuries that can happen for any laparoscopic surgery. These are described: tendinitis, trigger finger, laparoscopic shoulder. All these are described injuries that happen if you do long duration laparoscopic surgeries. So all these are circumvented by using the robotic technology. How is it possible? Because of intuitive movement. What is intuitive movement? You do some movement with your fingers, the same thing is replicated inside the patient's abdomen. That is intuitive movement. In laparoscopy, there is counterintuitive movement. Suppose you move the instrument, a long stick, laparoscopic instrument, up outside the body, the tip moves down. So these are counterintuitive movements. So the brain has to reciprocate it and understand all your movements in a different direction, because it happens at a fulcrum at the patient's abdomen. But this movement is intuitive in robotic. All our visions in laparoscopy are 2D images. You see on a flat screen on a monitor and operate. But in robotic, it's a 3D vision. What is 3D vision? You have got two separate eyepieces which gives a depth perception also. So it's a 3D real vision which we have in our open surgery. You have got endo-wristed movements. What is that? Our wrist can move a particular direction, a few degrees of motion. So all these degrees of motion is enhanced even in robotic surgery. There is dual console capability. What is that? A student can be there on the slave console, the master surgeon can be there on the master console. You can switch off your thing, you can ask him to do, at the same time you can keep watching. The point where he feels that you have to take up, you can stop him and you can start doing the surgery. So this slave and dual console capability is available in robotics. So with all these advantages, this is one small video of how a robot movement can be more proficient. So this is just a video showing how a human can replicate a robotic surgery. He'll demand or he'll tell the person to do all these movements. Then what is it? Even I can do that. That's very easy. Even I can do that. Then he tells, do these three simultaneous movements. And that's also possible. Even I can do that. Then he says, I challenge you, do this. So this is what is possible with this robotic endo-instead movements which you can do. Not only that, not only the movements, but even the precision. One can have the precision of peeling the cover of a grape and suture it back. So this sort of precision without any tremor. Suppose you have got a full cup of coffee or tea and you go and operate. Many surgeons would have felt your hands have a slight tremor. The caffeine in all these things leads to a slight tremor. So those tremors are stopped at the level of the robo itself. With the help of this, you can do fine surgeries. I'll show you probably in a video how we do a renal transplant also. There is one more thing known as remote center. What is this? All the movements in laparoscopy or open surgery, you give lot of traction onto the tissues to open and go into the deep structures. So this traction leads to myolysis. This traction leads to pressure necrosis. So all these things are circumvented by this remote center. What is this remote center? This is the point in the abdomen where the instruments go in. So this point is remotely fixed by the robotic patient cart, not to cause any shearing stress. All the movements happen in the air. So there is no pull or push happening at the level of entry. So that increases the patient's comfort and requirement for analgesia and anesthesia. So it causes less port pain. There is something known as tile pro integration. What is tile pro integration? Supposing you are doing some robotic surgery, at the same time real time ultrasonic image can be seen in the same console by the surgeon, which is being done by the assistant surgeon at the patient. So simultaneously you can see an ultrasonic image as well as a live image inside the abdomen. This is known as a tile pro integration. Not only that, you have got fluorescence imaging. What is that? You give a ICG, indocyanin green chemical intravenously, and you can see that it is differentially taken by the different organs. This is used for hepatectomies, for partial nephrectomies. This is a right-sided partial nephrectomy. You can see a tumor which is there in the lower part of the kidney here. This is how, after clamping the artery, there is differential perfusion from the tumor versus the kidney. So this is how, using an infrared camera. Basically, it is not a white light camera, it's an infrared camera. You just need to click one button on your console and you get back the white light. You can switch back to infrared, you can switch back to white light. So this possibility is there in this robotic system. Again, after you have unclamped, you can see whether the kidney is perfused or not. So this is known as ICG or infrared imaging. So where all the, because I am a urologist, I will be talking mainly about urological procedures that can be done using a robotic system. The maximum number of procedures that are done in a robotic system throughout the world is nothing other than radical prostate. That is nothing but the removal of the prostate which has developed some malignancy, CA prostate. The second most common is the renal cancers, kidney cancers. The third is the bladder cancer, and then we do a lot of complex reconstruction using the bowel to make the conduits and neobladders, and eventually the renal transplant. So these are all the surgeries we regularly do in robotics. One after the other I'll just run through. The most common one, radical prostatectomy, wherein all of us are aware that the neurovascular bundle or the hypogastric plexus goes around the prostate, and one has to preserve all this to preserve the continence. Otherwise you remove the prostate, patient will be incontinent, constantly leaking urine. So this nerve bundle preservation can be done comfortably using a robotic system. I don't want to go much in the technical part of it. So this is in deep inside the pelvis. If suppose you want to do this surgery in an open technique or laparoscopic technique, you need to give a big midline incision with lot of retractors just to see this area. Forget about doing this sort of a procedure there. So that is the seminal vesicles, vas difference posteriorly between the rectum and the prostate being dissected out. Then you drop the bladder, then you divide the bladder from the prostate, and that is the prostate being separated from the urethra. And once you have done that, you need to reconstruct also, suture back the bladder to the urethra. So that is being done now. So that's how a radical prostatectomy is being completed. I'm just fast forwarding it for the paucity of time. The second procedure which is most commonly done is a partial nephrectomy. What is this? This is a tumor in the kidney that has to be removed, not removing the entire kidney. If you go back 5-10 years back, if somebody develops a kidney tumor, it was only radical nephrectomy, removal of the entire kidney along with the tumor. But nowadays, because of the advancement, we are doing partial nephrectomies, that too robotically. So what do you do that? You score the tumor, you image it prior to the surgery, and only remove that part of the kidney which is harboring the tumor. Rest of the kidney, you preserve it. But the caveat, the most important point here is, you need to do all these things with the kidney clamped. Why is that important? Half of the cardiac output goes to the kidneys. So if suppose 6 liters is the cardiac output, 3 liters goes to the kidney. And if you give an incision onto the kidney, it's going to bleed to death. So you need to clamp the renal artery and vein and do the resection and reconstruction, suturing of the kidney within that time. If you clamp for more than half an hour, the kidney itself will get necrosed. So within that half an hour, one has to resect and suture. So that's how partial nephrectomy is, or it's a time-bound surgery. So this is an example how a patient is positioned for a left-sided tumor, that is the pneumoperitoneum being created with a carbon dioxide to insufflate inside the abdomen, and we need to put the ports. This is just to give an overview how a robotic system or a robotic surgery is done. So we mark all the ports, and then that is the first or the camera port which is placed inside the abdomen. I just fast forward it. That's an endoscopic camera which is introduced inside, and that is the view which you see from inside while we are putting the other ports under vision. So that's a left-sided port for the robo. That is an assistant port where the assistant has to give the suture material or cut the suture and all that. So that is an assistant port being placed. That's a right-sided robotic port. So basically with two working ports and one camera port, we are doing the robotic surgery for the left-sided kidney. Patient is in a right lateral position. So that is one more assistant port. So once these ports are placed, the robo is docked. What is docking? Attaching the robo to the arms. So that is how the arms are got near. And previous photo I had shown what is a patient cart. So this is a patient cart. That patient cart has brought near, attached to this ports onto the abdomen. So these are all disposable covers. These need to be thrown away after surgery. And the instruments are attached to these arms of this robo. So that is docking. This is known as docking, getting attached the robo to the ports, and this is putting the camera and the working instruments through those ports into the abdomen. That's the camera, 3D camera, and those are the instruments. That is the scissors being introduced from the right side. These instruments have got a life. After 10 uses, we need to throw them away. So that is the left side instrument. So both these instruments, once introduced inside, you press a button onto the patient cart. Now the movements are all done by the surgeon at the surgeon's console. So this is how docking and surgery is done. So this is a tumor on the right side. You can see a central tumor on both coronal and axial sections. There is a tumor in the right side kidney in the center part of it, like how you have got a seed of a mango or avocado. You got a center seed that you need to remove. At the same time, reconstruct it back, resect it and reconstruct it back within half an hour. So this is a right-sided renal tumor, and this is a 3D reconstruction that is available now. Previously, probably a year or so, this used to take around 10 to 12 hours to create a 3D reconstruction. But nowadays, with the help of artificial intelligence, you put in these DICOM images into the system, you get this image out, 3D reconstruction within half an hour. So you can separate the arteries, you can separate the veins, you can separate the collecting system. You can see how the tumor is in association with the vessels from the collecting system, and then you can score and plan your surgery. Which vessels to clamp, how to clamp, what is the approach, where to give the incision, all this can be planned. So this is a right-sided renal artery being looped. Once this is done, the vein is looped, and this is a real-time ultrasound which is being done on the table, and simultaneously visualizing it as to where should I give the incision to reach the tumor now. So after looping, now you have clamped, artery and vein are clamped. That is the IVC which is seen behind. So, that is the radial incision given onto the kidney. till you reach the tumor which is there in the center of the kidney there. So that is the tumor surface being seen. All these things has to be time bound. You have a time ticking, your stop clock is running, you have to finish in half an hour. Those are the pelvic ileal system that is stretched out over the tumor, and you start to reconstruct now. You have reconstructed by getting the edges together, putting some fat in between to fill the dead space, and suture back the kidney. Put it back and declamp it in 15 to 20 minutes. So this is how a partial nephrectomy is done. You use ICG and see whether it is bleeding, whether the kidney is reperfused back or not. If it is not reperfused, it is a dead kidney. So this is how a partial nephrectomy is done. This was again a case of a vesicovaginal fistula. This old lady had come for the treatment of her husband who has got a kidney stone, and she was standing far away from me. And I asked, why are you standing? You can take a chair. She said, no, I am leaking urine for past 35 years. Why? She had only one child, and during that child's delivery, she had a obstructed labor and developed a large VVF. So those are the two ureteric catheters placed. These are the two ureteric orifices, and that is a trigone area, the area beyond the ureteric orifices. And she has developed a big fistula there. Generally, fistulas are supratrigonal, area above the ureteric orifices, wherein this happens during hysterectomies and some other surgeries. But this was an obstructed labor and trigonal fistula. So no surgeon operated on him initially for last 35 years because chances of recurrence is high. Ischemic stricture. It's not a iatrogenic stricture. It's not a iatrogenic fistula. It's a ischemic fistula. So these ischemic fistulas don't heal so well because its reason for the fistula formation is ischemia. So she could not undergo that. So we told, anyway you have been leaking for 35 years. If at all this surgery fails, you will continue to leak. Why not try? And we did this rotation flap. And why I am telling you this is, this sort of a deep pelvic surgery with such a minimal access is not possible even in open surgery. You try to do it vaginally or try to do it abdominally, you will take a lot of effort and high chances that you will mobilize so many things, cause much more ischemia. But with the help of this robotics, we could go deep into the pelvis and repair this fistula. And after 35 years, she is now continent, not leaking, and socially she can get mingled with the other family members. Though she came for her husband's treatment, she was not even coming close. And that only child whom she delivered with an obstructed labor left her. So that is an omentum that is being placed in between the uterus and the bladder so that it becomes a vascularized flap. You need to give some good vascularity to that area. So that is the omentum being placed and suturing back both the edges. So that is the bladder flap closure being done. And last thing that I want to show is how a robotic renal transplant is done. Anybody is aware, how many of you are aware where a kidney is placed in a kidney transplant? Orthotopic position, the position where the actual kidneys are? No. It's placed in the right iliac fossa, and the vessels are anastomosed to the external iliac or internal iliac or common iliac. Okay. So this is a robotic transplant. Simultaneously in a separate operation theatre, the donor surgery is going on, and here in the recipient surgery we are skeletonizing the vessels, both artery and the vein of the common iliac and external iliac, so that when the kidney is given from the donor side, we don't waste much time and put it into the recipient and suture it back. So simultaneously the donor surgery was done, the kidney was retrieved. It was cold perfused because if you spend much time, again ischemia is the thing, you had to cold perfuse it, maintain the core temperature at -degrees, then put back this kidney, anastomose it and declamp it again in the given half an hour. So this is how the kidney is pushed into the abdomen through a gel port. This is known as gel port. Small opening, 4 finger breadths opening onto the umbilicus level. Put the kidney, put back the cap on it, and put the ports and dock the robo. Once the robo is docked, the external iliac vein is clamped distally and proximally, and this incision is given onto the external iliac vein. Now one more thing with this is, you are clamping the vessels supplying the limb. The lower limb is clamped. So there is ischemia of the kidney as well as ischemia of the leg. So one has to finish this surgery taking into consideration both the things. So this is the anastomosis of the. You might be thinking the needle is so big, the suture is so big. This is basically 10-0. You can't even see it with your naked eye. This is a 10-0 suture. You are seeing it at a very high magnification. You should not have air bubbles in it. So that has to be evacuated with a heparin saline, and then that is the last suture onto the vein. The left-sided instrument is a diamond tip needle holder. That diamond tip needle holder is used for this fine needles. Now the artery, external iliac artery is clamped, and the arteriotomy is done. Arterial pressures are high, so 2 clamps are applied now. That is the arteriotomy done, that is the heparin flush being given, and that is the renal artery to the external iliac artery of the recipient. That is the completion of the anastomosis and declamping. That's how the kidney transplant is done, and this kidney is placed back into the right iliac fossa. That is placement into the right iliac fossa and suturing the ureter to the bladder. If this was not possible, patient would have required a huge incision from the xiphisternum till the pubic symphysis. So this is done using only a small incision. A few words about the future of robotics, and I will stop it. So dual console, I told, this is how one can learn doing robotic surgery. Single port surgery, this is not yet launched in India, but this is what is already available, and I am proud to say many of our Muslim surgeons in US are doing a single port surgery. And see that you make a small hole through the umbilicus, again same arm movements, but all your instruments comes like a snake and open up. That's how you do the single port surgery. Again the controls and all are similar to a regular robotic surgery. You can go through transcavitary surgery, transvaginal, transhysteroscopic surgeries can also be done. Integration with imaging. Just now we have seen ultrasound can be integrated into the imaging, but going forward even artificial intelligence, CT scans, MRIs can also be integrated, and one can have a real-time statistics of how you are doing surgery. So this is my graph as to how I compare with any of the top surgeons in the world. So you get it in your phone. Once you finish the surgery and log out, you will get to know how much time you have taken for this surgery. So generally my students start doing the surgery, so that is my blue line. That's how much time we take for doing surgery. So all our PGs have gone for a conference, and I did the surgery skin to start, and this is how the time is shown. So you can compare with the peers throughout the world. So this is the top 10 average throughout the world. That is how much time they take. So all this is possible going forward. This is a 3D superimposition onto a liver tumor. Real-time ultrasound, CT scan imaging, and a 3D reconstruction all in a single console. This is not yet introduced, but this is in the development. This is the latest robo, again not yet introduced everywhere. This is known as Da Vinci 5, wherein All this while you didn't have the haptic feedback. What is haptic feedback? How much pressure you are applying onto the tissues you cannot feel, because these are all mechanical instruments. But this Da Vinci 5 has got this haptic feedback. How much pressure you are applying onto the tissues can also be sensed with your fingers. At what level you are applying those pressures, what is the efficiency of your hand movements, everything is calibrated. So that is the future of robotics. And that is how it comes in an intuitive app. There is an app for Android and iOS where you can see. There are few more tools which are available now other than intuitive, which I just showed, which I have Da Vinci Robo. There is CMR Robotics, there is Medtronics. Again, these two are British companies. This is an American company. And this is a Chinese robot which we have recently acquired, Medbot. Again, similar to Da Vinci, but made by China, half of the price. So going forward, I want all of you to get into it, learn all these things and develop, and there's no end to it. Thank you all for your patient listening. Hope I finished on time.
جزاکم اللہ احسن الجزا. ڈاکٹر صاحب نے بہت کم وقت میں زبردست تیاری کر کے موضوع کا حق ادا کرنے کی کوشش کی. میرے بزرگوں اور دینی بہنوں، ہمیں اللہ تعالیٰ کا اس نعمت پر شکر ادا کرنا چاہیے. ہزاروں پیجز کا خلاصہ، دسیوں زندگی کا نچوڑ، 85 میدان کا چھنا چھنایا تجربہ 1 گھنٹے میں چھوٹی سی مجلس میں اللہ تعالیٰ نے فائدہ اٹھانے کا موقع عطا فرمایا. ہماری قوم میں، امت مسلمہ میں ایسے باکمال، عظیم، جینیس، عبقری قسم کے لوگ بھی ہیں. ہمیں فائدہ اٹھانا چاہیے. الحکمت ضالۃ المؤمن. حضرت رسول اللہ صلی اللہ علیہ وسلم کا ارشاد ہے کہ حکمت تو ایمان والے کی گمشدہ چیز ہے. جہاں بھی مل جائے اسے لینا چاہیے. اسلام کے خلاف نہ ہو، اللہ کی نافرمانی نہ ہو. ہر اچھا تجربہ دوسری قوموں، دوسرے ملکوں سے ضرور اٹھانا چاہیے. یہ بات بار بار دہرائی جائے گی کہ ہوم ورک کرنے کی عادت ڈالیے. باسی مطالعے سے نئی بیماریوں کا علاج نہیں ہو سکتا. اپڈیٹ ہونا پڑے گا. پڑھنے لکھنے، نئے جرنلز، نئے ریسرچ، تحقیق کا مزاج بنانا پڑے گا. حضرت رسول اللہ صلی اللہ علیہ وسلم نے قرآن میں، حدیث میں دسیوں جگہ پر اشارہ ہے. احسان، احسان، اتقان، میچور ہونا، اپڈیٹ رہنا، اپنے سبجیکٹ پر کمانڈ حاصل کرنا، کوئی جھول رہنے نہ دینا، ہر تازہ معلومات کا حامل بننا اپنی پریکٹس کو مسلمان بنانے کے لیے ضروری ہے. پہلے انسان کا ارادہ کام کرتا ہے، پھر مشین کام کرتی ہے. انسان کا ارادہ صحیح ہو تو مشین صحیح استعمال ہوگی. مشین کا غلط استعمال ہوگا اگر انسان کا ارادہ غلط ہو. یہ ہتھیار، یہ مشینیں، یہ ٹیکنالوجی، سب کا صحیح استعمال انسان کے بننے پر موقوف ہے. اسی لیے اللہ تعالیٰ نے انبیاء علیہ السلام کے ذریعے سے مشینیں تیار نہیں کروائی، بلکہ مشینوں کو امانت داری سے چلانے والے انسان تیار کروائے. اللہ تعالیٰ ہم سب کو علم کا نا ختم ہونے والا سفر شروع کرنے کی توفیق عطا فرمائے۔ علم ہی وہ چیز ہے کہ جس میں اضافے کی دعا مانگنے لگوایا گیا، ربی زدنی علما۔ سب سے بڑا جاہل ہے جو یہ سمجھتا ہے مجھے سب آ گیا۔ اللہ نے قرآن میں فرمایا وَمَا أُوتِيتُم مِّنَ الْعِلْمِ إِلَّا قَلِيلًا۔